Welcome back to Join the Conversation. I am your host, Joe Goff. We're bringing you the boldest, biggest, brightest, and most innovative ideas in reimagining healthcare. Today, we're taking a deep dive into how technology and patient-centered thinking is completely disrupting the world of traditional surgery. Joining us will be Dr. James Clarkson. Dr. Clarkson is a double board certified surgeon in plastic surgery. He's in the UK and in Canada, which gives him reciprocity here in the United States. We'll talk about his journey in our intro and in his biographical introduction. The former professor of surgery at Michigan State University and current chief medical officer at both Wide Awake VR, the product, and Wallant Surgical Solutions, the company. And then you've got some things on the horizon with price transparency and other things that we'll get into. So Dr. Clarkson's journey, you'll hear his accent. He talks funny because he's from across the pond, as we say. But he spent 12 years in the British National Health Services and then became a part of our academic world here in the United States at Michigan State University. There was a fellowship at Kleiner Kurtz down in Louisville, Kentucky. And now he has set his mind at transforming experience for his patients in his practice, Heritage Hand, which is in Lansing, Michigan, just outside of Lansing. Is that correct?
That's actually on, Lake Lansing Road.
Lake Lansing
Central
Road.
Michigan.
So not too far from your old stomping grounds at Michigan State University.
Just up the road.
All right. So Dr. Clarkson, welcome. And please, first of all, give me the tale of three countries, really. Yeah. Your birthplace, where you were raised, and now where you spend your time with your family.
Yeah, so the birthplace, which is Canada, it still stays with me. I was there till I was 5, and it's heavily influenced, in fact, what I'm doing now, which is awake surgery, having really become the birthplace of awake surgery through Don Lalonde. But yes, I trained and grew
Dr. Don Lalonde, just to kind of the pioneering surgeon using a technique, depending on what your pronunciation is, but we'll say Wallant or Waylant. Some people say, but that's a long acronym for wide awake, local anesthetic, no tourniquet. And if you could please give the history of that and why it's so important to what we're going to be talking about.
Well, disrupting in Canada, they were faced with a lack of access to the operating room, the main operating room. And it gave Dr. Lalonde just really the edge on starting a process that was really needed to happen. Because he was able to take cases that he would normally have done in the main operating room and start offering it to patients outside of the main operating room, in the office procedure room, which really sounds as though they're not in an operating room, but well, a procedure room really is an operating room. It's simply not registered, and it has a smaller room, smaller space, but still sterile services, sterile technique, all the same.
No life support systems because they're not necessary.
Not necessary because everything's done under local anesthetic. And so really it's like turning a surgeon's office into a dental suite. This is the nearest analogy. Dentists have really always worked in their offices. They never really transferred their practices into the main operating room like surgeons did. Actually, if you go all the way back to the mid-19th century, offices were where surgeons did surgery. And then, obviously, we know the story there with sepsis, Louis Pasteur, Joseph Lister, Listerian asepsis, and then antisepsis. And the main thrust with Lalonde was that he could do things in the office that couldn't be done in the main operating room because there wasn't the ability to get into the main operating room, which really gave us the data to challenge the need for the main operating room for smaller cases.
And he had to overcome some mythology that existed in the medical textbooks around necrosis developing. Give me that snapshot of what he...
Well, if everybody believes a thing is true, it almost certainly isn't, and that's one of them. Epinephrine was considered a great shibboleth, a great taboo. For a long time, we didn't dare inject it into the nose, the ears, the fingers, the toes, and the penis. These were relatively low-volume areas that they had discovered when they injected local anesthesia in the 1920s. When it had epinephrine, they frequently found that necrosis occurred, and they couldn't understand it. So they said, well, it's because it's epinephrine. It's the epinephrine causing necrosis. And the anatomists came in, and they even came out with erudite concepts, like it's an end artery. It doesn't have collateral blood supply because it's the end of your nose or the end of your ear or the tip of your finger. And it became forbidden right back then. And once it was forbidden, things just carried on changing pharmacologically. For example, procaine, which was the local anesthetic of the day, became replaced by lidocaine, which is a much less toxic drug. They also learned something that they hadn't understood in the First World War, which was acid-base balance occurs when you're on shelf life. And the longer your substance is stored on the shelf, the more acidic it can become, which is why we see all these endless chemical names at the bottom of our drug files, stabilizing the drug to prevent it from becoming an acid with time. It was, in fact, the acid that was causing the necrosis. And the reason it was occurring in small volume spaces was because it wasn't washing out.
Understood. And am I right to assume that the reason why so many people started to question it is because they started seeing the evidence for themselves, like in battlefield surgery. They constantly injecting epinephrine in situations when they had to, and finding there was no necrosis occurring later on in the progression of this.
Well, I remember back in the 90s, they said, don't inject into the nose and the toesies, except they did. You couldn't operate on the nose or the ear without putting epinephrine in because it would bleed so much, because local anesthetic paralyzes your blood vessels, which means that they absolutely pour blood while you're doing surgery. So you couldn't do a delicate ear reconstruction or a tip of a nose cancer reconstruction unless it was flooded with epinephrine. So it was already proven not to be true, except we'd kept this boundary around fingers and toes. And indeed, today, when I speak to my urology colleagues, they still haven't moved the needle on the penis.
No pun intended.
No pun intended. So he moved the needle on that, and by trialing 3,100 patients throughout Canada, through a number of his colleagues doing the same thing, they found, of course, there was no digital necrosis. He bravely injected his own fingers and demonstrated, various stages of ischemia that all recovered, and it all made physiological sense as well, because the half-life of epinephrine is very short, and it doesn't cause tissue necrosis.
And he's this Don Lalonde is not done. Dr. Lalonde is still a huge advocate. He's still with us, very vital, and he's going to be with you in Boston here shortly.
Yes, huge supporter of the cause, and the cause is for him. I mean, he's an internationally known surgeon, so a lot of his work is third world in nature, because of their lack of access to anesthesia services, right? So the more you can do awake with the skill set that he's developed and the evidence that he's made, the more access to care people have. But also...
Just to stop you there, because it's so revolutionary, some of the things that are being accomplished. In Africa, for instance, he's got video of the coaching of a wide-awake mastectomy.
Yes.
Life-saving cancer surgery taking place with a surgeon that was executing it for the first time, with more experienced surgeons, obviously, in telehealth, coaching them through the process.
Yes, I can believe that.
And that's not a once-in-a-while thing. That's like happening all the time now.
You can, with very low concentration, large volume lidocaine and epinephrine, you can operate on wide areas of the human body, and it'll be completely numb. So in the forearm, I'm able to operate on tendon transfers, so we can move a tendon from the mid-forearm into another spot to help power a muscle that's actually paralyzed. But the largest number of cases that we use awake surgery for are the simpler hand surgeries, right? Because when you're running a hand practice, 60% or 70% of the patients who show up, they have trigger finger and carpal tunnel. Unless you're a very tertiary referral, very, very subspecialized hand surgeon who's only operating on the brachial plexus, that's the bread and butter of your practice. And so it makes complete sense that you would offer those to patients awake in order to free up space on your main operating block for the more complex things.
Sure. And there's a massive economy of efficiency in the scale of this. So let's kind of go through the laundry list. You and I have discussed this many times, but for instance, the patient doesn't have to have someone drive themselves there. They don't have to fast the day before. They don't have to get a clearance from their cardiologist and kind of run down the other things that most of your patients are so refreshed by.
Right. So my Medicare patients don't have to bring in their working children to accompany them to surgery and have someone else take a day off work in order for them to come in. You can drive to your appointment and drive home if you feel that you can control the vehicle. You always say that, but they haven't had a drug in their brain, so they're able to make decisions on their own. So if you have a surgery with anesthesia, you are told you are not fit to drive as though you've been to a bar. You can't drive.
And we're going to come back to that one.
Yes.
The narco fog effect of being sedated unnecessarily, we're going to come back to that one. But to run down the rest of that list, there's also a huge cost factor.
Very large cost factor. So, and this all comes down to the industrial nature of the way healthcare is delivered. So for a very long time, doctors made use of the operating room. Perhaps you might say too much. And shall we say take us till about 1965, the operating room was where it was at. In fact, doctors might even be guilty of admitting patients when they didn't need to be admitted, right? It was quite well known that there were admissions for patients who had had minor surgery, and we'll see you in the morning in the ward. And they would come and visit them and send them home. So the industrial nature took advantage of that, stripped out some of the unnecessary admissions, and tries to create a better business model out of it. But ultimately, what they discovered was that there's money to be made as well as saved, and the money to be made was the complexity of the way they were delivering it. So if you're delivering surgery in a complex fashion using life-saving anesthesia measures, ventilation, muscle paralysis, intravenous fluids, EKGs monitoring, having to have a CRNA or an anesthesiologist involved, all of that makes money. And unfortunately, if you are designing a financially rewarding program, that you're going to focus on things that make money as well as where to save money. And one of the things that makes money is complexity. And that's been running against the theme of common sense. The common sense is actually you never did need to have a carpal tunnel in the main operating room. You didn't need it in the 19th century. You don't need it there in the middle of the 20th century when we might have been overdoing it, and we certainly shouldn't be doing it there in the 21st century. From the hospital service point of view, their billing is a roughly 10 to 1 for the surgeon's cost. So a surgeon will offer a surgery. There may be a professional fee, which is one of those elements which patients aren't really aware of, but there's a particular code that the surgeon will apply that professional fee for. And then the hospital picks up an institution fee, which is 10 or 20 times a facility fee. And that facility fee is something that you can do away with altogether when you offer office-based surgery. I mean, it radically reduces the cost of surgery.
How many people do you think that are walking around the streets that you could tap on the shoulder actually understand that the surgeon doing the procedure is in some cases making 1/10 of what ends up on their bill?
Yes, I mean it's a confusing thing because there is one conflicting factor there, which is that if you're employed by the hospital, then you tend to have a guaranteed salary, which would imply that you're not just getting the CPT code, which is one of these pro-employment biases in the system right now. Which I'm learning the hard way, having deliberately left the system to set up my own private practice to understand what's going on. But if you're not employed by a hospital, you're likely to get considerably less for the same surgery because the pure code value has become devalued to a critical level now. The private practice, independent, a non-hospital employed practice, has become very hard to run based on those codes.
Is it the dirty little secret? And I don't want to go way off on a stump speech, but is it the dirty little secret that there are very few stakeholders, the patient and the employer that's paying for the patient at the end of the day? There are very few other stakeholders that actually want to see the pie shrink.
I know. But then you do see society's need for hospitals. And that's the confounding factor on that, because society says, look, we need a hospital, we need a trauma one here. How are we going to pay for it? And the ways they pay for it very often are to beg from Peter to pay Paul rather than simply pay the cost. By that I mean your hospital is funded largely by the activity in its operating room suites, which often are at the bottom of the hospital, a bit like a furnace. And that's what heats the hospital. So the more operating that you can do down there, the more profit that hospital derives from that activity, the more it can pay for what society also needs from the hospital.
The more emergency services.
And so rather than pay the price of the actual service, we're finding that insured patients are paying the cost of uninsured patients through unnecessary complexity. So if it was one thing to say you're going to pay more because you're well insured, so that you can justify that. But if you're going to pay more and also bleed more by having unnecessary treatment for something just to drive up complexity, that doesn't seem right at all. And that for me was a full stop. And having seen that for, I would say, roughly 6 years, I was doing very highly complex head and neck reconstructive surgery with microvascular work, which is really long cases, like 12-hour cases. I came to see that
that's veins.
That's actually
right?
arteries, and veins, and nerves, and flesh, and bone, all being taken from one place and put in another.
Restructured.
So I would
give me the meticulous nature of that, because I want people to get at least the visualization of why that takes. The microsurgery is a very nuanced specialty into itself.
It is. So we were reconstructing head and neck cancer patients who had failed radiation. So it was really the end stage of their disease, and I had a head and neck surgeon I was working with who would be removing a large amount of the face and the neck. And I was tasked with creating a swallowing tube for these patients to be able to swallow with, a place to place a valve so they could speak, a Passimere valve, a reconstructed soft tissue envelope for their mouth, for their cheek, for their neck. And we would be taking pieces of bowel, pieces of fibula from the leg, a large area of tissue from the outer thigh.
Complete reconstruction using other parts of the body.
Yes. But so that I think is important as a point of view from where I'm coming from, because that was the most highly complex surgery I still can't imagine much more complex surgery than that, although I give credit for many of my colleagues in other specialties.
And am I right to assume that in those situations, you would be more open to the concept of, hey, this takes a village, a team. You've got a lot of nurses.
Yep.
That's a heavy industrial, as you put, surgical environment. And therefore, facility fees in that circumstance might be fully warranted. Versus a carpal tunnel that you could do, maybe by yourself.
A 1-inch incision. This morning I did one through a 3mm incision using an ultrasound. They're getting much more minimalist than they even exist as of a few years ago. And so we've had endoscopic carpal tunnel releases. We're using ultrasound now to do it through an even smaller incision. And there's still a role for an open carpal tunnel release because, again, it's such a small injury in the first place, a 1-inch incision. But yes, it's a little different when you're reconstructing somebody's entire throat, face, and anterior neck and jaw.
Right. I don't want people to walk away from this thinking that we're anti-hospital. Hospitals serve one of the most vital purposes in the world we live in.
Right.
We just have to all stay in our lane of appropriateness, or we're all going to go broke as our GDP rises over 20% in the healthcare domain.
Right. So back to that employer-patient analogy that you were saying, they really aren't on the side of unnecessary fees, right? But that is the origin of those fees. I think that they can quite legitimately approach their local government and say, listen, we need you to support payment towards hospital fees. Otherwise, we're going to end up not serving your community. And where are they going to go? And that these are real legitimate concerns, which are clearly hard for people to reconcile. But reconciling it through kicking the can down the road and allowing complexity to be the answer, I think is about to yield its maximum and can't go any further.
There's a lot of that in the wind, isn't there? I mean, you've seen the price transparency legislation, and now there's going to be penalties associated with not being transparent or using obfuscation techniques within the release of data. I think there's also going to be what we have noted as clawbacks on payment. It seems to me, though, that globally, for everything that they seem to be taking away from health systems, there's 3 other areas where they're getting it back from independence, right? It seems one step forward for independent doctors ends up, when you follow the money, being 2 steps backwards in some other area that the payment model may or may not be putting on the front page, but hiding in the pork bellies of the legislation?
Well, again, the reason I took on a private practice was to understand the real politic of it, because I was hiding in a university. I mean, it was great. I was being paid for my productivity. They said, oh, you've done very well. Your relative value units, as they call it, were very high. I was being paid more than $500,000 a year, which I thought was a huge amount of money, and I think most people would agree.
Coming from the NHS, that's not doable.
Right, that's not doable.
In the UK.
But I also realized that you're also complicit if you do that. You know, you're not really addressing the problem. And I'd come out with all that virtual reality work that we had established, all the baseline data showing that helping to convince patients to have surgery in a low acuity environment like the office still took some behavioral modification. For me, and in the Lansing area in Michigan, my patients were, around about 20% likely to say no. And even now, when I listen to podcasts from my colleagues in the American Society for Surgery of the Hand, they talk about careful patient selection for office-based surgery. That all went away when I introduced virtual reality. I no longer had anybody who wasn't prepared to go through it. And I would have one patient after the next saying, thank you, I had no idea it could be that fun.
Yeah. So to highlight this, and we kind of skipped over this in the intro, we mentioned it, but we didn't dive deep enough into it. So one of the things that Dr. Clarkson is the pioneer of is immersive multimedia, virtual reality. It could be any, we're inventing new forms of multimedia, right? So it could be any immersive media. You chose in the beginning virtual reality as a tool to get greater adoption in what could be a harrowing circumstance for some people, saying, I'm going to do this wide awake. I'm going to numb up. There's going to be a nerve block. I'm going to numb up your arm completely. You're not going to feel this, but all I'm doing is throwing a drape over, and I'm going to be cutting you on the other side. Some people freak out with that.
I would.
My wife being one of them.
Yes, I would. I'm putting your hand through an unknown hole in a gauze. It's like putting your hand into a hole.
Sure.
I don't want to put my hand into a hole either. No, I like my patients to have a sense that they're part of the experience. They're not shut away from it. When we put a virtual reality headset on them, it's not a towel. It's not a ceiling with all the stains and strange leaks that they've seen.
Stare up at a television set.
Yeah, exactly right. You could do that. You can stare up at a television set. You could surround yourself with the intense music playlist of your choice. All of those things exist. Yeah. We chose virtual reality because that was a thing back then in 2016 when I started doing it.
Still viable.
Yes, it's still very viable because it's actually one of the best use cases for a technology that's not seen the best of times, actually.
Right.
Not a lot of people want to put a headset on when they're in company. But actually, when you don't really want to be where you are, it's a tremendous distraction.
It's the most immersive distraction because it does completely seal you off. There's no peripheral vision. There's no light leak. Right? You are in whatever content is being delivered, and you're a captive audience.
Right. You are. It's a show just for you. And there's a lot of development that could still take place in that whole area. We've just got some beautiful experiences that involve nature and intensely interesting.
So patient comes in.
Yeah.
I want to make sure that the audience understands this. Patient comes in, is presented with the idea that, look, sedation in general is not great for you. We've all heard the horror stories, right? There's a 1 in a million chance that you might be sedated and a bad event would happen. You're going to tell me that it's more than 1 in a million? That bad things happen. There's probably 1 in a zillion. We've heard these stories where people are awake inside their sedation and they're kind of restfully awake and freaking out.
Yeah.
I don't want to create, horror stories in the world of anesthesia, but there have been situations that if you could otherwise avoid it, you would like to. Certainly for people who are aging and have complex comorbidities, where lowering your blood pressure for that amount of time could produce cognitive decline that is persistent, meaning it doesn't bounce back.
They don't even know they don't actually even know all of the different causes for cognitive decline, but we know that there are several different classifications. One of them is postoperative delirium, which lasts for a set period of time, and then there's postoperative cognitive decline, which is longer. And I'll present to you a conundrum. We collect data on readmissions to hospital. In fact, the amount of data that we collect after surgery is frighteningly little. Death is very well collected.
Revisions.
And revision surgery, readmission within 30 days. Revision's not that well collected because revision might happen many months or years later that might well not be captured. In fact, a proper 360 reverse capture system, which is something I would really like to develop, would be much easier to do now in the advent of AI because of the enormous labor involved with collecting data from patients, which nobody does. What we do
Hospitals look at the 30-day window. Bundlers and conveners look at a 90-day window.
Which is still nothing. I mean, I might well find that somebody's had a trigger finger release that it came back a year later. It might well happen. That's not captured, and nor is the fact that you're admitted to a nursing home with dementia 3 or 4 years after your last surgery, having had multiple surgeries throughout your 70s, because it's considered the normal life event at that point. But when they have looked at the incidence of surgeries in a population of patients with dementia, well, one study shows that, it looks like it's related.
Yeah. The cumulative nature of surgeries in close proximity at advanced age has a resulting outcome that's negative.
It does. I think we should use the word anesthesia plus surgery. I think it's much better and more honest to say that, because one argument is that anesthesia may be reducing our blood-brain barrier, and that when you're then committing inflammatory events during that surgery and you have a reduced blood-brain barrier from anesthesia, it's the additive effect. But still isolated, if you didn't have the anesthesia, you shouldn't have the compounding effect of a blood-brain barrier issue. So, but it's still hard to point the finger exactly where the problem is, because every piece of data reflects anesthesia plus surgery. We don't do anesthesia without surgery.
Right. Well, some people do, but that's recreational and illegal in most cases.
Yes.
But if we flip that back to just think through the studies that are not done, okay? Because that's what we're talking about, is the absence of evidence, right? Another thing where there's a complete absence of evidence that you and I have both had discussions with groups like the NIH, is that there's no study being done on events that occur, domestic events that occur that cause accidents in the home, whether they be driving or household domestic accidents, within X number of days of being sedated. There seems to be some considerable anecdotal evidence,
I can tell you a few,
that these events occur at a much higher rate when you're in that narco fog a few days after surgery.
100%. So after I finished doing the head and neck stuff, which really had a very high mortality and morbidity from it, I was pretty sensitized to my patients not having any problems, right? So one of the things that I noticed going forward was, after some of my minor hand surgeries, I was seeing minor or one or two major problems. One of them was a minor stroke the day after surgery. She recovered, but she needed admission. She didn't have any permanent outcome, but it was a serious event, and it was not very, it was a very surprising event. And all I'd done was transfer a tendon across the back of her hand, which I now only do in my office. Another one was a chap who was admitted. This wasn't hand. This was a minor plastic surgery where I did a graft on a leg. And it was, again, something I started doing under pure local anesthetic after this event, because the operating room couldn't get the equipment together. We ended up spending, I think, an hour and a half under anesthesia over something that I know I take like 20 minutes over in the wound clinic. And he was admitted to intensive care. A month later, he was admitted with a really serious pneumonia. So again, not unrelated. And then finally, I had an interesting lady recently who we were just doing sedation. She'd insisted. She said, "Look, I'm," and she had some financial reasons as well why she was a Medicaid patient, which actually drove her into the hospital, which is another subject altogether. But her policy would really only work in the hospital. So she was there, and of course, she was getting sedation. She'd asked for it. She was prepared to have sedation there. And during her sedation, she ended up having a PTSD kind of event where she was writhing and fighting us off during her sedation period, in which she was supposed to be relaxed and asleep, but not in deep general anesthetic. But she ended up getting essentially fighting drunk. And that is something you see sometimes under sedation, and you don't know whether it's going to happen or not. So we had to, hold her down, and they intubated her and put her to sleep. Well, the next time I saw her, which was 2 weeks later, she walked in with a walking frame because she'd pulled her back.
Another domestic accident.
Yes, and I'm pretty sure she pulled her back on the table. She was arching her back like she was in tetanic spasm. So it's quite, it's not light. It's not a light event being unconscious. And I've had surgery myself and blissfully unaware about what happened when I was asleep.
And that's the point that I want to make.
Yeah.
We are not crying foul at the industry of anesthesia and anesthesiology. Yeah. The point here is that all things have limitations.
Right.
All things have sweet spots where they worked perfectly, and areas like the aging population where, for instance, a university came to me in the southern United States and said, we need to get a risk stratification tool from you because we have surgeons that won't stop doing hip replacements on 90-year-olds, right? Once you get to a certain age and you're at a certain activity limit, these major surgeries, replacing shoulders and hips and large area surgeries, are dangerous.
Yes. I mean, yes. And that's why minimalism is really a feature of awake surgery as well. So I'm just going to put you into a slightly different frame of mind. So if you're a surgeon and the patient's unconscious, your surgical technique can be fairly maximal. It can be that much deeper, that much quicker, that much longer, that much more aggressive. Everything's quick and easy. When the patient's awake, you're much more careful. It's like tiptoeing around a sleeping baby. And you're more minimal. If it's like, shall we do more or less today? Provided it's reasonable not to do more, you don't do more. You tend to stop where you are. And therefore the patients are less likely to face the consequences of more aggressive surgery and actually one of the things we have seen from awake surgery, and it may be that this is one of the contributing factors, people recover more quickly.
Yeah. And it's important to note that anesthesia and the innovations around anesthesia are what has empowered healthcare to keep us alive a hell of a lot longer when we do experience trauma. So again, just like those hospitals that we said are absolutely invaluable to the American and global way of life, anesthesia is invaluable.
Yes.
We are not criticizing it entirely. It's the limitations and how far the pendulum's been allowed to swing.
Just look at what they were doing in the 19th and 18th century. It was the end of agony. Are you gonna touch on your family history? Yeah, I can talk about that because I've got some stuff.
And just to preface it, so your grandfather,
right,
post World War I.
It's actually two.
World War II was his sweet spot, right? So this is, but the research came out of World War I, if I'm correct. Was really a pioneer in sterile services.
Well, so yes, you're confusing him and his. So yeah, there's a. You're not supposed to know. So basically, So Patrick Clarkson, my grandfather, was a plastic and hand surgeon in World War II. So that's a second generation plastic surgeon. The first gen were for World War I. Yeah, he was faced with systemic reasons why his patients weren't doing very well. So if you had a missile injury, that would be a bullet wound or a blast wound to your face, which is one of the things that he was treating. The World War I had taught them, because they were usually dirty and long lines of retreat, so already infected, they'd taught them not to try and close those wounds. They would all get infected, so just leave them open and send them back to London, and very slowly Harold Gillies and other great plastic surgeons would reconstruct them over a period of time. But that time was not available in Cassino in Italy. There were no lines of retreat. We were pushing the Nazis up through the Italian spine. We were in Cassino. He was in North Africa. And in those places, those missile injuries were fresh. And he actually sent people right to the front line to debride them and get them closed right away. And it was entirely wrong to do that at that time. That time was, no, you leave them open. That's what Harold Gillies told us to do, and you should do what you're told. So he did it differently. He published it, and we now would regard that as exactly what you should do. You always debride a dirty wound ASAP. You have a golden window of 3 to 6 hours to get these things clean, which is exactly how we operate in the main hospital now. If a patient comes in and they've got a contaminated wound, it's like straight into the operating room, get rid of, literally cut out all the dirt and get it closed. The other thing he discovered was that if you're burned, and this was the first time they ever had blood transfusion service in the world. So like the first world blood transfusion service. You can cut the burn off, transfuse the patient for the blood loss that they're getting, which they could never do. They would have killed the patient. And if you did that, they healed much, much more quickly. So that film, The English Patient, which actually is set in World War II. So that film, he didn't meet my granddad. My granddad would have cut that burn off and had him grafted. He wouldn't have died quietly in that hotel room in that movie. So that was being treated on World War I principles. And in fact, there was a maxillofacial burns unit I think the film was set in Croatia or somewhere around the Middle East. And so there was a unit there, but it was a traditional unit. It was following traditional methods. In other words, you can be faced with circumstances as a surgeon, and it's really your choice to look at the actual environment that you're in now, not the environment that you were trained in, because the two are not the same. He was trained in an environment where there was no blood transfusion, but now he was in an environment where there was blood transfusion. Grow up, get on with it. And you look back one generation before him, his wife's grandfather, this is what you were talking about with sterile technique. Now, he's called William Lane. So William Lane was in the area where Listerian antisepsis existed. So Joseph Lister was this famous antisepsis hero of the British surgical tradition, who in about it was the 1880s came out with this idea of putting phenol on everything, carbolic acid on absolutely everything, and indeed reduce the infection rate from a very, very bad infection rate to better. But what Lane realized was that, no, this still isn't good enough. You can't cut down on a closed fracture and put a plate on that fracture, because that always gets infected. You've got to do it differently. But something had changed. A German called von Bergmann had invented an autoclave out in Germany. And Lane didn't speak German, but he got someone to translate the paper and went, this is something I want to know more about, because he'd already read Louis Pasteur's work, which was actually just before Lister in about the 1860s. And he put two and two together. In other words, again, things had changed. There was a new technology. There was some new thinking, and he brought it all together, and he was the first person to put plates and screws onto orthopedic fractures, for which he was rewarded with a medical investigation. And it was the first... No
good deed is left unpunished.
Right, it was the first and almost only evidence that sterile technique works. The British Medical Association couldn't find a significant infection rate in his population of patients.
So what I find fascinating about it, because we've referenced it several times in this conversation alone, and I'm sure there's many more examples, is that when you are under great duress, like wartime medicine, innovation seems to sprout because there is no other choice but to attempt things. And in that world of high stakes drama on the battlefield, you're willing to give some things a chance that you wouldn't have been willing to had you been in the cozy atmosphere of an operating room.
Yeah. Does that mean you shouldn't innovate in peacetime, Joe?
All I'm saying is that it seems that we made massive strides under great duress, whereas we might be much more incremental and conservative in our approach when we aren't in desperate circumstances.
Well, we didn't have what's called the Joint Commission, or JCO, in the Italian theater of war in 1943. But that is a dampener on innovation.
And please don't think that I am making a case for warfare. I am not making a case for warfare. I'm simply exposing a point of view that innovation does seem in medicine to crop up more aggressively when desperate times are of the moment.
Well, so the nice thing about the office is back to the main operating room, which is a dampener. If you're under an intensely regulated mainstream process, it is very hard to move the needle in terms of change of practice. They're incrementally slower. But actually the procedure rooms around the United States, and indeed most international procedure rooms, with the exception, I think, of France, which is pretty regulated, but many procedure rooms are virtually unregulated. Now, that's a bad thing in some ways, right? You really have to impose some very, very high standards of behavior and training under those circumstances. But also it means that we're not completely stuck in the 40-year past. Because where do these regulations come from? Incremental past experience. And past experience is no predictor necessarily of future experience. And so one of the exciting things about the office, and I'm looking forward to seeing this flower over the next 10 years, is the evolution of newer surgical techniques and things that we just wouldn't do in the main operating room. One of those I'm doing already, which it had already been discussed elsewhere, I've seen it, is releasing trigger fingers without an incision. And, you wouldn't necessarily have ever done that in the main operating room. You're equipped with a knife and not an 18-gauge needle, but you can actually release a trigger finger through the skin, through multiple little stabs with a needle. Again, remember, less is more. You're going to tend to do less when the patient is awake because you're walking around a sleeping baby. You don't want to make things more than they have to be. Yeah. So you come up with innovative ways to do the same job with less. And that's going to be an evolutionary pressure on the office. And it's not just going to be restricted to hands. It's going to move to podiatry. It's going to move through to vascular surgery. A huge amount of vascular surgery goes on in the office already. All those vein clinics are by definition the office.
I hope that it, and I know that we're going off of but you play in the orthopedic space, even though you're a plastic surgeon. The very, very low success rate long-term of back surgery has got to be addressed with innovation. We cannot live in a world where 80% of the patients 18 to 24 months after surgery are reporting a pain score that's the same or worse.
Well, I'm not a back surgeon, but maybe they're maximalist. Maybe that's the thesis here, is that perhaps if they were forced to be more minimalist, they may come up with more elegant solutions.
So let's move on to office-based procedures. We've talked about this, but when we move patients to the office, it isn't just the elements that we described around efficiency. It's not just the elements that we described around cost. There's also a hell of a lot of convenience for you.
Right.
Everybody forgets that when a plane goes down or we save the doctors first because they're going to save everybody else, right? Like, we need doctors to have a pretty high quality of life and feel that they are professionally rewarded so that they can optimize care for all of us. And I know that for you to address that is
it's a big deal for the surgeons, but your podcast must be more for patients than surgeons. But as surgeons, we are becoming an increasingly small denominator in a very, very overwhelming financially driven system. And actually working for a government as I did, the British National Health for 12 years, it's just the same if your system is run by a corporation or a government. And I would argue they're almost the same. I actually could argue they are the same, but that's another podcast. And so when you move away from that, there is a tremendous amount of enjoyment and freedom that comes with that. Freedom to spend time with your patients in the way you'd want to.
You're an entrepreneur at that point.
Yes.
You're independent.
Yes.
You're running a business.
Coming up with creative solutions like providing my patients with a web app that allows them to make their own diagnosis as to what's likely to be wrong with their hand, and then offer them a free spread of all the local prices in their region as to what it would cost to get done in their local hospital, their local ASC, and how much might it cost in their local office hand surgeon.
And this is so what Dr. Clarkson is describing is something that is extremely important to me. I know it's important to you, that more patients get more information and more employers, the stakeholders that we talked about that are completely aligned with creating savings and efficiency at a high quality with the price transparency component. So, can I pay cash for this under circumstances when it would very obviously benefit me? Please just show me the calculator. And you've done that. You've built the calculator that allows me, the pedestrian on the internet, to say, under my deductible, with my copay, with my plan, with my HSA, here's what makes the most sense with this procedure.
Precisely. And in fact, it also gives them the opportunity to discover for themselves what might be driving the pain that they're complaining of in their hands. Because time and time again, I'll have somebody come into the office.
So it's a symptom checker too.
It's a symptom checker. And actually, we might have had these, obviously we've had people, the Google Doc environment we've been in for 20 years.
ChatGPT has tools.
Well, that's getting there. So that's different, though. I think ChatGPT and Gemini and things are getting somewhere that Google Doc never got to, that WebMD never really opened the can on. I don't want to knock a proprietorial brand, but they've now got the ability to say, well, these are my symptoms, and what could it be? Before it was kind of you would just get diverted to one person's
logic
website.
Tree.
Yes,
yeah, you're in a machine learning logic tree.
Something better. And when I was at medical school, they used to teach me listen to the patient. They're telling you the diagnosis. And I think with AI, we actually have a time now when we've got to face as physicians that the patients are going to come pre-diagnosed to see us. We just have to accept this. We're here to facilitate and accept their treatment plan.
But sometimes you get in there and find something isn't what you thought it was going to be.
Well, that's why we do that. But that doesn't mean that they shouldn't have a good idea. So my web app gives them the chance to explore what might be wrong with them, what options would exist if they needed to have surgery, and how much would it cost wherever they choose to have that done.
Sure.
I haven't seen something like that in my entire career.
And they can find this at heritagehandsurgery.com.
They can. It's under pricing.
Under the pricing tool. And you've kind of opened this up to humanity.
Yes, it's there. I mean, it applies to my local. Well, we can get onto the subject of how do you discover how much it would cost in Nebraska.
You've localized pricing.
Localized pricing around Lansing. Because what I discovered is, and you and I were touching on this before the podcast started, is we're only just entering a period of true transparency.
Right. Where the fines and the penalties are going to force people to give up all the information in a way that's much more machine readable than maybe they've done so far.
You were one step ahead of me because when I looked, actually I couldn't find it, Joe.
Yeah.
So
there are sleuths who have perfected the digestion of this publicly available data and found ways to deliver price transparency to us. I'll mention Seraph as one that we've seen.
But they're subscription based.
Really they cost money.
I would like to see it being accessible by a chatbot. It should be reasonably accessible by a chatbot, just like being able to Grok goes to X to find out whatever's chatting about on X, and they use these other. What's the other forum they use? It'll come back to me. It should be possible. Reddit, precisely, commonly used by AI. They can walk through Reddit. I mean, that's a great way of finding democratic view.
Used to be Patients Like Me. I know that got bought up. Patients Like Me was another place where you could share and see other communities of people that were dealing with the same thing. They found all kinds of things like Crohn's patients having strange reactions to hoppy beer and craft beers that doctors didn't realize. I mean, there's the things that happen when you crowdsource intelligence and a lot of people with the same conditions come together in an environment and share their experiences.
Yes. Things
emerge that are very obvious patterns and trends.
Yes, I suffer from your hoppy beer problem as well, Joe. Yes, but where do you think transparency could lead us? Because I think transparency, the American public will not put up with what they find out.
I think there's a lot of considerations that go into this, so it's not just that component that's driving this. What I'm about to postulate. But I do believe that more and more, this is going to be a world of where the independent doctors are moving to a direct to employer, direct to consumer contracting models that we refer to as DPC, models that we refer to under the convener structures where bundles are priced. These ideas of cash pay and direct contracting, getting the insurance companies and all the middlemen that are stacking up dollars and extracting wealth from the transaction that could very well be much more simplified.
Yeah.
I do think that the technology is now here and the political pressure is now mounting to where that reality is going to exist.
Yeah, I wish it was sooner. I really do, Joe. Having
Let's put it this way.
Yes.
I think it's under a generation away.
Yes, right.
It's not right around the corner, but it's under a generation, meaning my children will experience this.
Right. Yes. Do you think it could replace some of the state approaches, state monopolies, such as the British National Health and the Canadian health system?
You know, I mean,
Both of them are dear to me.
I don't want to get into a political,
yeah.
you know, the
Old enemies.
the pendulum swings. So, I mean, we have a very considerable movement right now for socialized medicine in the United States.
I know, it's just worrisome to me.
It's worry. You know, some people. You know, it's hard for me to pick a side in that world because, like yourself, I have dabbled in the National Health Services as a consultant for the NHS with the Clinical Entrepreneurs Program. But in the same token, I live in a world where the free market economy has driven the greatest innovation on the planet. And, you know, I've seen both of them function well, and I've seen both of them function very poorly. So it's very hard to like stick a flag in the ground and say it's got to be one way. I think it's going to often be a blend of these systems. And I know people don't like that because that is vagary and uncertainty, but you know, complexity by design has been around for a long time. And a lot of people make a lot of money off of complexity by design.
Well, complexity is bad for you, Joe.
I agree. I'm not justifying it.
Yeah.
I'm saying that its clenched fists are going to hold on very tightly to the status quo of complexity as long as they possibly can. What I'm telling you is that I see a world where the simplicity of cash pay and the simplicity of contracting outside of the prior authorization, third-party administrator constructs that are so far from what we understand as proper transactions will hopefully disappear.
I mean, I've learned so much in the last year and a half being independent from my university. It used to be that they simply rewarded me for the work that I did. They would sometimes mumble that they weren't collecting very much, but I didn't really see why they wouldn't collect it, and I used to suspect that they just were a typical university, not really following the beans. Well, actually, I now know there are payers out there who simply don't pay if they don't want to, if they don't feel like it. And I'll call it out. I mean, I treat Medicaid patients. I mean, I always have done. I'm a British National Health doc. It just doesn't seem right not to take anyone's ability, whether they want to pay out of pocket, bring their insurance. I'll try and create something that's affordable to them if they haven't got insurance. And then I discovered that 50 of my own state's Medicaid patients, the only 50 that I'd seen in 8 months from a particular plan, had simply not had a single payment received from that Medicaid policy. And I was parring with that policy. And in fact, I was reading yet another letter from the same policy. It's an HMO Medicaid plan. And they just simply said, well, yes, we don't have to pay this. We've discovered that the doctor who referred the patient to you wasn't the registered doctor for Medicaid in our HMO. It was their colleague.
Well, we'll take this one off. We'll take this one off the air and identify this payer and figure out what we can do to.
It doesn't help if the state gives this HMO money for them to then make it impossible for me to treat Medicaid patients.
Exactly. It's that type of restrictive behavior, and I mean, there's no other. It's greed.
Right.
I mean, at the end of the day, that is the complexity by design. Is to greedily hoard what you were supposed to distribute to the rightful physicians doing the procedures.
Right. Yeah. And those are the things I've learned, along with a whole bunch of other things.
Well, you know, you've been more than fair with your time, but I want to, before we close, I want to give you an opportunity to enlighten us with any other elements that are on the horizon, any new innovations on the horizon. But I want to start this wrapping up process with a question. Do you see an eventuality in this cash pay world that we both hope comes to fruition, where clinically integrated networks, physician-led clinically integrated networks are the full value institution that takes control. Can doctors combine forces? Can we generate solidarity amongst physicians to come together and say, look, enough is enough. We're the product. Yeah. This is what I say in a lot of my speeches to doctors. Yeah. You are the product of healthcare. And yet you're letting yourself get used and manipulated like tools.
Correct.
By the puppeteer who is mastering wealth extraction.
Correct. And that is the hen in the fox house, or the fox in the hen house, rather, situation where we are naturally thoroughbred competitors. That unfortunately is a feature of the way we train. I mean, you get out of medical school, you get the right score, you get into a program, you get out of that program, you get the right references, you get into the better jobs, you get less good references, you get less good jobs, or you travel further than you wanted to work. Everything's about how good was that guy compared to me. And unfortunately, that still hangs around a little bit. I mean, the best of us try not to do that. But it's extremely easy to assume that the competitive nature of your residency and medical school existence still means that we're competing with each other. And I frequently try to remind fellow hand surgeons who are doing work in the office that we're not competing against each other. Even if there might be a patient that one snags over another, we're really in competition with the entire system. That's our competition.
As an independent.
An independent. And that is one of the messages that I'm actually going to be delivering to the American Society for Surgery of Hand this September. And it's also one of the reasons why Dr. Asi Filius and myself set up Wallant Surgical Solutions, which is a network. We have 40 people, 3 of whom are currently active. We're a growing funded network allowing surgeons to offer surgery in the office where the money follows the patient. And in this case, it's from employers looking not to pay for that facility fee, but they're willing to encourage doctors to do more work in the office by paying them a little bit more for that that particular
professional
code,
fee.
The professional
fee.
The
1/10 of the cost.
The 1/10. And when you run an office, by the way, your office costs $350 an hour. It's a battleship. It's like having a yacht in the most expensive harbor out in Petoskey or somewhere, So you got it sitting there, and it's costing money, and that doesn't get paid for by a professional fee. So our network is going out finding different ways for surgeons to get paid more. One of them is a self-insured. The other one is patients who have very high deductibles, and this is one of the great injustices and one of the strangest areas of law. Because you can be in network with an insurer. Let's just name an insurer. No bad thing. Let's say United. You're in network with United. A United patient comes to your office with a $10,000 deductible and says, "I don't want you to treat me as a United patient. I just want to pay you whatever you take for this because I know it'll cost me $8,000 in the local hospital. What will you take?" It would be a contravention of my contract with the insurance company, the most favored nations and all these things that they put into these contracts, to accept anything other than the fee scheduled agreed amount, which is that professional fee. And that's one of the areas that's really holding back office-based surgery right now. And it's one area that is really entangling many hand surgeons. So
what you're suggesting is that a lobbying initiative of some kind, a legislative push, should exist for a consumer to waive their health insurance in any episode of care that they want to pay cash for.
Well, because they've got a $10,000 deductible.
Seems fair. It's their money.
And it's their free. They're a member of the United States. I mean, why shouldn't they spend their money where they want?
They're not paying their premium.
Right. All of it's wrong that the surgeon should be told not to accept their money. And I'm going to leave that because there are there are surgeons who are risking that. They're doing so by asking their patients to sign a thing called the High-Tech Act, which actually prevents a surgeon from divulging the treatment that they've had to their insurance company. But again, that just puts them in jeopardy. The insurance might well claw back after many hundreds have been treated. It could be 5 years down the road, and suddenly you're facing some unpleasant action from an insurance company. All of it's unpalatable, and it's really, frankly, unfair on the patient.
I want to go back to WSS.
Yes.
Because that's Wallant Surgical Solutions.
Yes.
Okay. This is it's a network
Yes.
of surgeons who are doing office-based procedures in many cases, some of them in ambulatory surgical centers,
Yes.
But mostly moving to office-based procedures. This is mainly upper extremities.
Yes, was starting with upper extremity.
Okay.
And
But we can move to lower extremities. This could be podiatry. This could be dermatological procedures.
or urological procedures. I mean, I wish to goodness, I'd had VR for my vasectomy. I can tell you,
Sure.
I can tell you that.
Sure.
Our network will have availability for offering surgery with or without the virtual reality, but under local anesthetic in the office, and the money should follow the patient to see that doctor.
I'm going to introduce you to Dr. Berlanga up in Midland, who's doing the no suture, no scalpel vasectomies.
It's too late for me.
I know, but in general, because the WSS network is going to be very intriguing.
Yes.
These proceduralists are out there, people who do these procedures in the office.
That sounds like an example, by the way, of what I'm talking about, the evolutionary pressure of office surgery towards simplification. So he's simplified a vasectomy, is what you've just told me.
That's right.
Spot on. That's exactly the evolutionary pressure that the office will force on surgery. And ultimately, surgery went through its expansion at the end of the 19th century. It saved lives, millions of lives. But it also became overcomplex. It's not just anesthesia. We are just over-complex in general. And by removing some of the forward momentum, by pushing people into the office for simpler procedures, we will decomplexify.
So your tools, the calculator that we discussed, is at heritagehandsurgery.com.
Yes.
WSS and these network of surgeons is at wallantsurgical.com.
That's right.
WALANT, surgical.com. Is there anything else that I've forgotten about that we haven't?
No. I mean, we're a young company with a young network, and we're growing. We're presenting ourselves to the American Society for Surgery of Hand to get more than 40 surgeons into the system. We're really pushing hard to get these what's called third-party administrators. These people are looking after the health plans for large companies, and these companies are beginning to understand what we offer them. It is an awfully slow process, Joe. The lifespan of startups, we're like Mayfly compared to medicine.
Yeah.
We get about 3 years, and if it hasn't gained traction in 3 years, then you have to pivot or refund or.
And you're also to prolong and enhance. You are talking. I don't think I'm releasing anything that's proprietary. More cash pay solutions where you want to be a marketplace for cash pay.
We want patients to be able to find us. We want patients to be able to legitimately say, I have a $10,000 deductible. Where is the cheapest place for me to get this? And what might be wrong with me?
Or I'm in the gig economy and I don't, the marketplace was too expensive.
Right.
So I just want to pay cash for this problem I have.
Millions of Americans are underinsured. And although we see figures that suggest it's a relatively small number, that's because they have had insurance within a certain period of months, but they'll go without insurance frequently. And you've only got to go to Indeed.com or any of these frequent re-employment agencies to understand when you move away from a job, you lose your insurance.
Yeah.
And their kids have Medicaid. Their husbands might have some form of insurance fixed to their employment, but it's probably going to just cover them. So there's a lot of people in the system, a lot of them are women, who are moving through in and out of insurance policies. And actually, I know this because I employ them. I'm very pleased to say I've given them PCN insurance because they came to me with no insurance. And this isn't an unusual situation, and I don't know why.
So you've seen it from the employer,
as an
stakeholder
employer.
position, as an entrepreneur running
Yes.
Heritage Hand.
Yeah.
And you've seen it from the surgical experience. I mean, and then as you just described, I mean, we both have had the experience of being under the knife also. I mean, we're all patients at some point in our life.
My gallbladder is somewhere else right now.
Yeah, we're all patients, so that's important to remember. But the last thing I want to tap into is, again, I know it's a selfish circumstance to put you on the spot with this, but isn't it so important that we make sure that our surgeons, especially the independent doctors, whether they be primary care or surgeons or specialists in between, have a pretty high quality of life and aren't burned out, stressed out, trying to figure out. I mean, you went to school for a long time and developed a specialty that saves lives, that improves lives, that this is something that we are not putting enough priority on as a society to protect our independent physicians.
Correct. I mean, in fact, one of the first decisions I made with my practice was to strip my electronic health record down to the barely legal. And that's because the law requires a certain level of complexity that I didn't ask for in my health record system. And when I'm in a hospital, again, naming no proprietary brands, but we have one dominant system, which was there right at the beginning of the Affordable Health Care Act.
Sure.
And lo and behold, meaningful use criteria were effectively set on the operating system. And they have never helped me have any meaning out of my use.
A considerable pile of wealth extracted via taxpayer dollars.
Hogwarts Castle in Wisconsin.
Yes, the subsidy-driven government-backed payment plan for EHRs.
Yes.
Yeah.
Yes.
Well, I'm not going to probe any further. Again, Dr. Clarkson, it has been interesting. It has been a exploration, a little bit history, a little bit future facing.
Yes.
We've gotten kind of everything in between. I'm very happy that you could join us. Again, I'm going to give the plug. You are Heritage Hand as a surgeon entrepreneur.
Yes.
Your companies, Wallant Surgical Solutions at wallantsurgical.com. You're going to have a cash pay. You've already got the calculator online, so if people want to look at the price transparency tool, they can do so. We're going to see more and more of you because the media blitz is coming. More and more people are interested in this topic of paying cash pay for their services in healthcare.
And surgeons are going to work closer together. That is why we're networking them.
And a lot of that's going to be taking place in Boston coming up in September.
That's right.
That's your next big step.
That's right.
It was great to have you, and thank you for joining the conversation.
Thank you, Joe.